Welcome to the office. Welcome to the office, Larry.
Thank you.
How
Glad
can
to
I-
be here.
See ya. How can I help you?
Well, I'm really super stiff in the mornings. It is super bad in the mornings. And then,
What is super bad in the morning?
just lower back both sides. Mostly on my right leg it goes down, mainly on the top, but sometimes it goes to the back.
Wait, are we saying that you get the shooting pain from the back down the leg, or the whole leg is hurting?
No, just just muscles kick off or something, I guess
Okay.
you would say. Shooting pain, I guess.
Okay.
But it's really sore in the both sides of the lower back, just like that.
Started when?
Last October is when it started.
You've had stuff going on for a while here.
Yeah.
So
Yeah.
let's rewind a tiny bit.
Okay.
And let's talk about the first low back injury that you recall.
Probably when I was 12 or something. I used to jump bicycles.
Oh, nice, okay.
Yeah, and I
Half
landed.
pipe, quarter pipes?
No, not that kind of stuff. Just big ramps. We were Evel Knievel type of guys.
Oh, nice,
Yeah,
okay,
yeah.
right
And
on.
so I would land and bottom
What kind of
out
bike you
on-
had?
It was a Stingray, just a Schwinn Stingray
I
with
know
a
the
banana
Stingray.
seat. But there's no suspension, and so when we bottomed out, we would just hit that seat. And I did went to a chiropractor back then too after the injury, but evidently I did bust my tailbone or crack it or something at that point.
Okay.
So that was the beginning of it when I was about 12. Since then, I was a truck mechanic for a while, so a little bit of heavy lifting and what have you.
Okay.
And always being bent over like this, working under a hood. And so,
Sure.
So I did that for about 10 years. Now I do plumbing and it's easier on the back.
That's the first time someone has said that. And that's what you're here for?
Yes.
The low back.
Yes. Well, and
What else?
my arms get, they've always been weak since that surgery, 2010. My fingers tingle on
What
both
happened?
sides. Oh, I crashed a motorcycle when I was racing.
So number one reason you're here is the bilateral back pain, stiffness in the back in the morning. You have shooting pain, or we'll say it's the back and the right leg.
Mainly.
And
yeah.
it doesn't go past the knee all the time. It's
Very
usually
rarely.
just to the knee.
Yeah.
Right?
Yeah.
Okay. You have a laundry list there for me?
Oh.
What's that?
2 weeks ago, it's done it twice in the last 2 weeks. All of a sudden I'd be walking and all of a sudden this leg would work again. And it just felt almost totally normal. And then I guess it corrected my posture. I went up and then because I was walking correctly for about a half a day or something, then this side started to hurt because I don't know what happened. It shifted, but then, and it did it again, it did it twice. And then now after it did that, now I'm having problems with my knee because I don't know why.
It's shifting back and forth.
It did, yeah.
Okay.
So now it made this one grind a little bit different, I guess, and it.
Okay. I'll
yeah.
explain all that to you.
Okay,
I'll
yeah.
explain all.
And this knee's been worked on twice on my meniscus.
Arthroscopic or?
Yeah, arthroscopic.
Okay.
Yeah.
No hardware.
No hardware.
So the only hardware is in the neck.
Yeah.
Okay.
Yeah.
All right.
It just feels weaker when I look down. It just kind of like it's pinching something or something.
Are you getting weakness or numbness or tingling in your hands when you look down?
No, those are kind of all the time. It's been that way for a long
Okay.
time.
Sit up straight.
Yeah.
Now, tell me as you're looking down when you start to feel that. How far down?
Right about there. Just I can feel it just kind of
From up
lose a little bit
here?
of power. Yeah, it's just like going not all the way. It's not shutting up. I can feel it kind of draining power when I look down.
Okay, so this is important, guys, and this is also a good test, simple functional test.
Yeah.
After, at the end of the visit, we're going to redo that, and you'll tell us if anything is different.
Okay.
Fair enough?
Yeah.
Okay, what else?
When I turn my neck to the right, I can't turn it far to the right. I'm good left, but I can't go to the right.
Okay.
And then digestion is bad.
Yes, I agree.
Okay.
Okay, so let's go over this, Larry. I'll go over your
Okay.
x-rays. And first thing I want to do is this. So yes, we can see from right around L4, it starts to go to that right side, tilting, and then it starts to compensate back here. When was the surgery when they put the clips in the neck? You said?
2010, January.
12 years ago, okay. And so the first thing is, do we have a level foundation? We're off a little bit, aren't we?
Yeah.
Okay. Let's look at the numbers and let's see what the numbers mean. We have at the moment, it says 2 millimeter or 2 MD, 2 millimeter measure difference. With correction of the pelvis, it becomes a 1 millimeter actual difference. But it actually will switch sides. Now, let's talk about this left SI joint. This is where all the issues started. We have a rotated pelvis on the left side. We have a rotated sacrum on the left side. And this is a classic in page 43 of the chapters, guys. When you have a rotated pelvis and a rotated sacrum, which one do you do first? So Dr. Gonstead came up with this based on his 55 years of work. And what he found was if you have an ASIN on the side of a rotated sacrum, or an AS or an IN major on the side of the rotated sacrum, you do the sacrum first. If we had a pelvis that was down and out on that side of a rotated sacrum, we would push it up. So page 43 of the chapter states when you have, but we're also going to do a functional test to confirm that. Okay? Because not everyone's textbook. They're just not. Now, you got quite a bit of scar tissue going on in here. And before we get into that, you can see this 3 millimeter differential, right? So the right sacrum is 3 millimeters down. You've had a couple of good tailbone, at least one good one, but you've had a couple of good tailbone injuries.
I have.
Now, so let's put this together. The left side goes up one and in. IN meaning it turns in. The sacrum on the left side goes to the left. So the overall effect is what? Your body is favoring the left side. Your foundation wants to go left.
This is the stronger side.
And which way does your spine want to go, dude?
To the right.
So there's your disconnect. In your case, this is actually interesting because I talk about the smooth arc, right?
Mm-hmm.
And his arc is pretty darn smooth here, guys. Okay? There's a little something here. It's very subtle. But the overall smoothness, you know, a lot of times we see these nubs or these, yeah, we'll call them nubs. All this white stuff is all scar tissue. You have a BP sacrum. So his sacrum is posterior to both 5 and 4. He has a base posterior sacrum rotated on that left side. From that, there's been instability here of L4 on L5, and you can see this. This is calcification of the disc of L4, and what that tells me is you've had this for a period of time. I'm also starting to see a bit of calcification along the abdominal aorta. I shouldn't be seeing that. So if I'm seeing that on an x-ray, that means you've been eating pretty good. You've been enjoying pretty good food, haven't you?
Too much good food.
Yeah, I think so.
Really?
So some stuff we'll talk about later, okay?
All right.
The only thing, if I see something like that, the question I would ask somebody is, do you get temperature changes in your feet? Do your feet get cold? Do you get circulation issues?
I don't know. Ever since my accident, they've always kind of tingled, so I don't really...
Tingle? Do they get cold? Or you don't really notice?
Not really. I lost maybe some of that feeling during my wreck.
Okay.
Yeah.
All right. The idea here is we're going to be working on your sacrum and your tailbone. We're going to need to push it forward and get rid of that rotation. As we go up, here's what I want us to see. So we know this is all off here, tilted, but then look what happens. It comes back to level very close, very early, right around here. We have a little bit of calcification of that disc. This is an old compression fracture, old compression injury you had. As we're getting to the neck, guys, okay, this is kind of important now. You can see he's got some hardware in there. He had a pretty traumatic accident.
Yeah.
And this is another first for me, guys. So I have people that have 1, 2, 3, where 2 vertebrae are connected. In a way, it was a good thing the way they did this, because if they would have fused the whole thing together,
I lost mobility.
you would have lost a lot. Okay? Thanks, they did their job. They saved you. Okay?
Yeah.
So we want to thank them for that.
Yeah, I'm just glad to walk,
Yeah.
let me tell you.
So, and as you look closer now, it's this. Let's go closer. If we need to work on this one, I'm okay with that. If I need to work on that one, that's going to be pretty gangsta. So the idea with pressure, right, and what we're doing here as well, we're looking for the nerve pressure. Now, the fact that these have fused together, they fused that, right? They put them together. They filled it up with whatever the nerves. See, you can see the nerve holes. Like up here, there's a lot of rotation in his neck. His discs are still good. 2, 3. 4 disc is not there, 5 is there, 6 is not there, 7 is there. Okay, so we can deal with 7, I can deal with 2 and 3. I hope there's nothing here, and the reason why is this is there.
Got a little nub on it. That's the nub.
That's the nub. But again, it is what it is. Wherever the pressure is, that's our job, to clear nerve pressure. First thing we want to do is a plumb line. We're taking the lowest lumbar, running it straight up. And you know what, dude? You've held pretty well, dude. I'll give you that. And so we said we know that there was an injury in the tailbone. You can see a lot of whitening on this right side. That's all that scar tissue. We're probably going to be starting down here on this side here. Okay. And as you can see, the tilting of the spine, this is all calcium buildup. The body is trying to stabilize. Digestion, we're looking at the Blvd. It's this circle here. It should be a big half black circle. And all of this is, you got a little bit of gas, but there's a lot of undigested food going on in there. And that stuff is all going to start to change today. You ready for it?
I'm ready.
Alright. And last thing I want to do is go over flexion extension. Now we already know you're going to be limited because of the hardware.
Right.
That's neutral. That's extension. That's flexion. And we're probably going to be working on the base. So I'm okay working on the base of the neck. I'm okay working on the upper cervical in the neck.
Okay.
I'm okay working on the foundation. I don't want to be messing around with anything in the lumbar area up here because it's compensation. All of whatever's going on here is
caused by the body.
Correct. And you can see that over here. I just want to clarify this. So this, remember, this is tilting. So all this is shortened, all this is elongated. So I know you get up, you're stiff.
Oh, yeah.
You're stiff. Like,
yeah.
And it takes a while.
Until 11 o'clock in the morning.
So let's see if we can change all that, okay?
Let's do it.
Let's do it. So this is Larry. He's antalgic to the right side. You can see just from the antalgia, the crease here, no crease here, okay? Swelling is not too bad, but again, you can see this whole thing just kind of veers to that side and then comes back. Go ahead and walk for me, please, Larry. You're going to walk several times back and forth. How are the knees? Pain-wise?
It's not bothering me today. This one's a little bit tight. I don't know if it looks swollen.
Looks a little swollen compared. That's why I was asking. But again, all of this could be a function of the foundation, right?
Yeah.
So you can see how he moves. You can see that he's tilting like this, and he's just moving that left side. That right side's not really moving. And if we go back to the X-ray, it's because there's all that scar tissue, calcification on that side. So the whole right SI joint hikes up. So it's not that he's getting an individual motion this way. It's like this is what I see. And what I want us to see is, let's see the dimples and see what kind of motion he gets. Raise your left leg first. And down. Raise your right leg. There's a lot of pain, and there's no movement here. Do the left side again. So at least he has a tiny bit of movement there. Here, nothing's moving. Do it again. Yeah. Okay. Starting at the base of the neck, head down, please. And the first thing we're getting is 15, 20 points. He's 71. All right, 23, 24 points. 15 points, right side up top. Mm, 10 points, T7, T8 area. There it is, my friend. S3, 10 points. S3, S4. That's around T7, and that's C7. Now, let's go ahead and statically palpate. Now, in his case, guys, I'm not going to be doing the motion of the pelvis that you normally see me do. You already see it's all stuck. It's not moving. So what I want to do is this. I want to do static palpation first. Now, what's interesting, if the research has changed, I would really like to know, because what the research used to show is there's no research with motion palpation. So motion palpation may tell you a segment is stuck, but that's all it can tell you. It doesn't tell you why. And 1, 2, 3, 4, 5, 6, 7. Between static palpation and motion palpation, if you guys can figure out static palpation for edema, swelling, point tenderness, it will give you more information than motion palpation. 7, 1, 2, 3, 4, 5, 6. Tender there, sir. Number 8 or number 7?
7.
Number 6 or number 7? Number 8, no. Starting at 7, is 6 more tender or 7?
7.
7. That's that sugar button. That's your sweet tooth, dude. This is number 5. Number 4. Good. So even just tilting him or bringing him back in extension, he wants to go to the right. He's making me go to the right too. There we go. You see? So instead of going back, he goes to the right. Right there, sir. More tender here or here?
I think the upper one.
That's S2. 5, number 1, number 2, number 3, number 2.
2. I even felt a little bit at 1, 2.
But below, you felt a little at 1, but we still, 2 is also there.
Yeah, 2.
3 is also a little bit there.
A little bit too. Yeah.
So
but
I
2
would-
is probably the most.
2 is more pronounced?
I would just barely, yeah.
Okay, so I would be at S2 slightly on the left side is where we're gonna, is what we're gonna do on the sacrum. T7, PL sacrum. Sit back for me, please. But we did say that before I do the low back, I'm gonna do the Gonstead leg check, and the Gonstead leg check will confirm if we're gonna do the sacrum of the pelvis. Oh, you talking about that movement?
Yeah, going to the right. It's really stiff going to the right.
Yeah. Well, that's coming from a lot of this stuff up here.
Probably just my accident. I don't know.
That's the scar tissue. Okay. Let's go face down and do the leg check, sir. You're going to go face down over here. Now let's look at the legs. Relax them for me the best you can. So on this, you can see the left is slightly shorter. We're going to bend the knees to 90 degrees. If it stays short, sacrum. If it goes long, pelvis. And it still stays short. So we're going to do the sacrum. So we're going to be on that left side. Elbows out, palms face up, and receive. Focus on your breath. It's so ready to go, dude. There it is. Good. And that's the home run. Nice. Very nice. You made it. 1, 2, 3, 4, 5, 6, 7. Oh, wow. That one's going to be a bugger. Gotcha. Nice. Like butter.
I didn't even feel a pop.
What are you talking
It
about?
must have moved.
It moved. I moved. Oh, yeah. Oh, yeah. Hold my hand, please. You wanted a joint fart? Is that what you wanted? I want to get out. All right. Let's have you walk 2-3 times, please. You'll do well in a pool, okay, sir?
Okay.
Just so you got that buoyancy, you can get more fluid motion. Anything different?
It feels like I'm wobbling a little bit less, but it's an improvement, I can tell that, but it's still tight.
Yeah. Let's get that neck now, okay? A common question I get a lot is, can you adjust someone after surgery with hardware in their body? And the answer is yes. And I'm going to show you today. And we're going to do T1, C2, 3, 4, 5, 6, 7. Oh, interesting. That's what threw me off. Okay. So he actually has cervical ribs. 70% of the vertebral prominences is C7. Yours is T1. Okay. Relax there, please. Let me do the work now. Try not to help too much. Feet out, resting on your heels. Good. T1. T1, so we need to stabilize nice and firm, and we're setting up. Relax there. Oh wow, you got to drop. Let it go. Gotcha.
There, that was it.
Wow. Walk it off, sir. And you'll just walk once this time and come back. And we're going to just recheck on the meter. Good stuff. Have a seat, please. And let's recheck. Neck is clear. 7 is clear. Dude, you're back to being a 0.
You're kidding me.
No, I'm not. You get to see the video later, okay?
That neck adjustment did seem to do, I could tell when I was walking, it seemed to do, I could tell a difference after the neck adjustment.
What do you mean?
I don't know, it just felt like I wasn't, my legs were more evenly proportioned a little bit.
From the neck, not from the back adjustment?
Yeah, from the neck, I noticed it get better.
Interesting. Can we test something out? Do you remember when you looked down?
Oh, yeah. Yeah, it doesn't get numb no more.
A little different, right?
Wow, yeah.
Cool.
Yeah, it's gone. Wow.
Shall I continue?
Yeah. Mr. Gorilla.
Look to the left, look to the right. A little different?
It's better on the right. I couldn't go that far before.
Cool. Now, let's set the shoulder. Relax the elbow. Let me do the work. There you go. Drop it down. There you go. There you go, sir. Raise your right leg. And down. Raise your left leg. You don't have hardware in your knee, you said, right?
Yeah, it's good.
There you go. You got a bicycle at home?
Yeah.
Okay. Stationary or a regular bike?
Regular bike.
Okay. So I'd like you to put it against the wall and pedal backwards every morning, 5 to 10 minutes.
Okay.
That's the best rehab for your knee. Let's take a look and see the difference. Back towards me. Number 5. Number 1. That was 2. A little different. Must be. Okay.
Yeah.
All good, dude.
Nothing was sharp.
Stand up for me, please. Go ahead and walk for us, please. It's different. Pretty cool. Okay.
Yeah, it is a little bit different. I could tell a little bit. Still getting shots down here, but it's better.
I'm not worried about that right now.
Okay.
Okay? We had to start somewhere.
Right.
That's a plumber hand. That's like a concrete guy. The guy who does masonry. Squeeze. Squeeze. Hands are solid, dude.
Yeah.
I'm not messing with your hands. Okay.
Well, I think they are stronger now than they were before the treatment, to be honest with you. Yeah.
They're strong. So.
Yeah.
One more time. Maybe I should have checked it before.
Yeah.
Any questions for me, Larry?
No, I think that's good.
Okay.
We'll see you when we see you.
Welcome to the office.
Thank you.
Pleasure.